I'm Peggy O'Kane, president of NCQA. I founded NCQA 35 years ago. We've made a lot of progress, but as I prepare to leave NCQA, I feel there's unfinished business. That's where this podcast series comes in. I'll be talking with some of healthcare's brightest thinkers, executives, researchers, and innovators working for real change. These conversations are for people who are curious and want to help the U.S. escape bad health outcomes and runaway costs. This is Quality Talks. My guest today is Will Shrank, one of the people I know who's had the most storied career in healthcare and been looking at it at all angles and is an incredibly good thinker about it. One of the themes that's emerging in these podcasts is why isn't healthcare better at getting better? That's the overarching theme. But I'd like to ask you, what do you want healthcare to be, let's say 5, 10, 20 years from now?
Oh, that's a great question, Peggy. And it's great to have a chance to speak with you. This is part of the Peggy celebration. So as a huge fan of yours, I'm excited to be part of the crew that gets to celebrate you. The thing that I hope to see change in the healthcare system is we figure out how to work more like a system. We have lots of great services and features and products and tactics, and we have the best technology. We have the best intentioned people. We have all the pieces to make what should be the healthiest population, but we do not have a good way of getting all those pieces to work together. There's a lot of reason to believe with all this improving technology, with efforts around aligning payment models, there's a lot of momentum that should get us to more systemness rather than a ton of point solutions. I hope that's where we go.
I love that answer. NCQA has been about systemness from the beginning. It's a hard thing to explain to patients of the American people because system has funny connotations for people. But it's also hard to explain to doctors and nurses. So I wonder if I might ask you to think about that. How do we get everybody on board for the undoubted benefits that more systemness would bring?
There are a couple pieces to that. One is, how do you make it easier for folks delivering care to interact with colleagues? How do we break down the data silos, structural challenges to integration? And then how do we create the incentives for those delivering care to make that a priority? Frankly, two areas that I think NCQA has been uniquely engaged over the last number of years and where NCQA has a really important role, both around that vision for a more integrated data platform that allows for higher quality, more integrated care, and also a mechanism for rewarding, for creating the right goals and objectives of providers so they do see the outcomes as the ones that we're trying to model and a system as the best way to get there.
Yeah, it's clear to me we're not going to get far unless we can get the people who are delivering the care on board with this. It's one of my big musings that quality measurement hasn't been very good at getting them on board. In fact, many times they don't like quality measurement. There are a lot of reasons for that. But I think what you're saying is it's going to make life easier. Their lives are really not a lot of fun, right?
To add to that theme, most providers see quality measurement as a reason for more work and not necessarily distinguishing the efforts they do to meet the needs and understand the priorities and preferences of the patients they care for. And there's a gap. These quality indicators all make sense. Every one of them has a rationale, clear, evidence-based reason for being a measure. But more often than not, it's not the thing the provider thinks is the most important thing they did that day. They know if they're getting measured on it, it's work for them to track it and go back and figure out how to fill in gaps. So it is this trade-off of the work of tracking against the outcomes they know they're being measured against? And are they truly the priorities, the most important things that they think are important for focusing on the outcomes that they're trying to produce with their patients?
Well, we've been on this journey trying to digitalize quality measurement. And I have to smile when I think how naive we were to think, oh, if we just do that, the measures will fall out of their care delivery process. And that is how ultimately it should be, right? We all have that scenario of the doctor in their pajamas at night entering data into their laptops. Nobody wants that. Nobody wants that. But it turns out that this is complicated because we've got a lot of, let's say, fragmentation in the data they are confronting. There's no sort of short-term fix for that, it seems to me. But I wonder if there are some things that are more foundational to that.
Data fragmentation is something we're all sensitive to. Anyone who's caring for a patient sees the fragmentation as a barrier to having the information you need to take great care of someone. And the lack of that information also puts you at risk of doing wasteful, repetitive, unnecessary, low-value services. So those gaps are important in being able to deliver better quality care. Those gaps are also meaningful in our ability to track our own performance. And the lack of simple ways to sort of quantify in closer to real time the opportunities for the patient in front of you or the population you're serving is a barrier to optimizing how providers delegate their time to the tasks that are most important. But a bigger issue is less how good or bad is the data. I think the bigger issue is, do providers feel like the measures we're paying them on are capturing the stuff that matters most? Are they the measures that really matter? Process measures are incredibly important. Getting to outcomes measures are awesomely important. But increasingly, things doctors do that truly make a difference are more nuanced. And the way to capture them requires a more nuanced and thoughtful way of maybe fewer measures, but measures that capture a variety of behaviors, a way in which the provider and the patient collaborate on the health outcomes of that patient. One of the things we've talked about many times, Peggy, is instead of looking at specific behaviors for someone with diabetes, can you look at diabetes progression? Can you look at a provider's ability to work with a patient or work with a population and slow the progression of the illness and the downstream macrovascular adverse events from the disease? That's a hard measure to come up with. And it's hard to know how to compare to other groups. But that's something that totally resonates with providers. If I can do a good job of slowing the progression for my patients of a disease like diabetes, I'm doing something important that's going to majorly impact the quality of their life and their ability to enjoy and live a life without suffering. It's that progression from simpler, more binary outcomes to something that really captures the quality of the relationship, the quality of the interaction, and the ability to change health trajectories. Feels like where we as a healthcare system need to go if we want providers to believe that those measures are the things that matter most to their patients.
Yeah, it's interesting. We've been doing a lot of work on this, and you've heard about it. Progression to renal failure. We had a meeting on this. We had some of the best minds in medical science. We also had two patients in the room. One is on dialysis and one has had a kidney transplant. And they both said, when I found out that I had a kidney problem was when they were telling me I was going to have a transplant or I was going to go on dialysis. It was very interesting because the doctors were all aware of it. They were just kind of flummoxed by the complications and the limits of what they could do. But it led to them not bringing the subject up because it was awkward or because they were worried they were going to worry the patient more, although it might have been good to worry them a little earlier. It's interesting because I don't know if you've ever heard of the patient activation measure. Judy Hibbert invented this survey that measures how much patients get engaged. And somebody that's working with it said to me the other day, the moment you are told you have kidney disease, you have diabetes, that is a moment of activation, big time. People really do. They understand. It's interesting. So let me just switch topics here and let's talk about the incentives in the system. Who said the system is perfectly designed to give us the outcomes that we're getting? I don't know if it's Don Berwick, but for sure, it's far from perfectly designed. It's perfectly designed to give us the chaos that we have and the amount of money we spend. So I wonder if you could speak about that a little bit.
Yeah, I come to this discussion with some humility as somebody who's sort of there. I worked at the Innovation Center when I first started and believed and continue to believe there is a way to get to better incentives where there's deeper alignment between how we're rewarding providers and systems and the outcomes we're trying to produce. If you look at our healthcare system broadly, it is not intuitive. We have a vision as a country around how we're going to pay providers to drive better outcomes and a more sustainable healthcare system. Every payer's got a different way that they're paying providers. There's massive variation of the kinds of payment models providers have available, and providers have a lot of choice. And they choose with their feet based often on how they were trained, what the culture's like in the communities they live, the systems they work in. With some humility, I feel like we as a health system have done a pretty lousy job of creating clarity on what the payment model of the future should be. At this point, I think we kind of know what it is. We know what the payment model of the future should be. And I'm disappointed that we haven't done a better job of getting.
But why don't you say what it should be, Will? Everybody's waiting.
The future has to be some mechanism where primary care docs, I prefer in collaboration with a broader integrated system, but not necessarily, where primary care doctors take meaningful upside and downside financial risk for the cost and the quality of the care that they provide to the populations they serve. Once that becomes the foundation, where primary care docs are at risk and feel deeply accountable and responsible for caring for the populations they serve, a lot of those other relationships work themselves out. Relationships around how specialists are paid allows you to sort of create an umbrella, if you will, where you nest or you pay all the other providers in a way that's aligned with, so whether it's on some kind of a bundle or some kind of a subcap, but is all underneath this broader umbrella of a primary care risk model. And I feel like when I see all the different models that are out there, where sometimes it's hospitals taking global risk, there are lots of specialty risk models. It's too complicated. There are too many different paths to take. It's too messy. We just have to make this simpler. We got to make it easy for doctors to do the right thing and to create the right relationships and to set the right paths. I think most people would agree. A model where primary care docs have some meaningful accountability for the populations they serve would be better than what we have today. And if we as a system decided that's the direction we're going to go and make that the North Star, I think we in a much shorter time could get to efficient, higher quality, and deliver better outcomes at lower cost and deliver more equitable care for all Americans.
So do we have enough primary care doctors?
Probably not.
And how did we get there? Was that an accident? Also designed.
I think so. You got to probably get the incentives right and build it right. I mean, I went to medical school. I chose to be a general internist because I had this weird vision, this kind of convoluted sense of what my career was going to look like, and I was totally off. But a lot of people are just thinking about, I got lots of loans, I got to figure out how to make this work. Now I've got a fiance. They're very practical reasons people make their decisions. And we have to make it easy to make the right practical decision that actually drives better outcomes. Yeah.
Absolutely. So I wonder if you could talk about waste. Waste in medicine doesn't seem to be a story that gets a lot of traction. Health plans get a bad rap for doing prior authorization. Sometimes that's going after waste. Sometimes it's going after harm. It doesn't always work perfectly. And it's a major source of negative feeling towards health plans. And it's admittedly a very awkward way of going about things. So my incentive is to save money. Your incentive is to burn more. And so that's always going to result in some friction that's not going to be pleasant. And I think it's really undermined people's trust. So I just wonder if you could talk about waste. A lot of it is under the radar, and I know you've written about this. Maybe you could just say a few words about the things that people don't think about that are big sources of waste in the system?
Well, first of all, just to say it out loud, one person's waste is someone else's profit. We have waste for a reason in this country. It's not an accident that we haven't thought about it. We have waste for very clear reasons. And as you noted, I did some work trying to measure and characterize the cost and the sources of waste in the US healthcare system using categories that were generated by the National Academy of Medicine and that were made famous by a landmark article by Don Berwick and Andy Hackbarth in 2011. It showed that somewhere over a quarter of the spend on healthcare is waste, which in today's dollars is over $1 trillion. We waste more dollars in the US healthcare system every year than is the GDP of like the 15th biggest country in the world. It's extraordinary. When you think about what would happen if we could reduce that waste and reallocate those dollars, we could solve a lot of today's problems, social problems. The biggest source of waste, if you break it down, the biggest source of waste is administrative complexity. Anybody who's worked in healthcare is not surprised to hear that. That's a huge way any provider spends their day, whether it's prior authorization, utilization management, billing, the mechanics of getting things paid for is burdensome. A lot of that is driven by the fact that for years and years and years, we had a fee-for-service arrangement where providers are trying to get paid for doing more stuff and purchasers are trying to reduce the number of things they don't have to pay as much. And even the move towards value-based care has done very little to mitigate. And in fact, when we redid the Don Berwick, Andy Hackbarth study 9-10 years later, we found those numbers really hadn't shifted. The shocking thing was just how consistent those numbers stayed over the decade, despite all these efforts around moving towards value-based care. And it really did highlight, you can come up with a great concept, but you have to implement it on the ground in a way that meaningfully changes the way practice is being delivered. We also looked at the evidence from interventions to try to reduce waste, to see where the evidence would suggest there's the best evidence of the best implementations, the best strategies, the best tactics that actually can actively reduce the amount of waste in the healthcare system. And the places where the evidence was published and where there was meaningful green shoots were in settings where value-based care was being tested. We did see in care coordination, care transitions, and low-value care that the sites where there were evidence about new strategies, new implementations, new structures to reduce waste that were successful were, without exception, all in settings where value-based care was implemented. So it does suggest that it's necessary but not sufficient. It's necessary to create the right incentives that are aligned around the outcomes we're trying to produce. But just saying, hey, we're moving in this direction, but not really investing and creating the right infrastructure, you need to jump in with both feet if you're really going to make a difference. You got to really test new interventions, focus on delivery. It's not just about incentives. It's about changing the way we practice, and doing so can meaningfully move the needle when it comes to waste.
So let me take you back. You're looking at primary care, having a payment model where they have both upside and downside risk. And we know a lot of the spend is going to be happening on the specialty and the hospital side. If those doctors are working in a system that's dominated by a hospital, how is that going to work? If the hospital is on a heads and beds model, is that going to work? I think the data show that in the ACO world, the Accountable Care Organization, it's independent physician groups have been most successful. But I don't know that they're smarter or more effective. They don't have this countervailing pressure, right?
Yes, I think that's right. And B, it also changes some of the dynamics around how they think about how they collaborate with a specialist. Frankly, having worked in health systems where I, as a primary care doc, was the lowest paid member of the chain, and where even though I was in a value-based arrangement, I never felt like my outcomes meaningfully impacted the check I got at the end of the month. And the specialists were the kings of the institution. If I had a capitated population in an outpatient setting and I was being thoughtful about who I referred my patients to and I had a understanding with them And we even figured out how to create financial alignment between us, between the primary care doc and the specialist around delivering better outcomes at lower cost. That's where the magic starts to happen. And then in that setting where you've got primary care docs taking more and more risk, even if it's within the system, then you start to force the specialist to come to the table with new approaches where you're not just subjected to like, it's all any of the specialists do around here. They all do fee for service. So that's what I have to go with. If you start seeing better options that allow you to create more alignment between the specialist and the primary care doc, I think those will be successful models. It'll drive more volume, more sustainability, deeper relationships with the referring primary care docs, and it can create a flywheel around alignment of these financial models.
Thank you. One of the critiques of our system, and I buy into this big time, is it really doesn't do well at keeping you healthy. And there's a lot of philosophical talk we can have about how much is it your responsibility and how much is it the responsibility of the system. But I think it's a moment when we have Make America Healthy again. We have a secretary who I think has a lot of the right ideas about wellness. NCQA is going to try to embrace this mandate. And so how would we go about that? What do you think is the right way to go about that? We know people getting nagged about their diet and smoking and all that isn't always popular. So what do we know that can make this run at healthier lifestyles work better than our past attempts?
I don't think there's a simple, easy silver bullet on this. And I don't generally love the idea of paying patients for doing the right thing. It should be in our best interest to be healthy. We shouldn't have to get paid for whatever healthy behavior we're trying to pursue. The notion that providers are aware of the behaviors that patients engage in and care about them and talk about them seems really salient. The biggest challenge is that around the payment model, investments in prevention take a long time to have an ROI. We're at this weird spot where like the right thing to do is hard. It's just hard to come up with an ROI around the same way that we think about like investing time and energy in patients that reduce adverse outcomes because it'll lower total cost of care. It really isn't true when it comes to prevention and keeping people healthy in the first place, because that timeline just takes too long. So I think we have to somehow come up with a different way of capturing and rewarding that. That's not just simply how many ER visits are you averting or how many hospitalizations are you averting. I don't think this is easy, but I do think this is the job of NCQA. When we think about measures that matter, keeping people healthy in the first place and slowing disease progression are two things that we can all agree are super duper important for everyone. And understanding that and capturing that and measuring that and rewarding that seems to be at the core. This dates back to, Peggy, your work in the patient-centered medical home and trying to figure out how to get primary care docs to organize their practices around these very same themes. This is not new for you. It's definitely not new for NCQA, but it's hard to do. And it's hard to kind of really crystallize those measures in a way that we know how to link incentives to them. But I do think this is exactly the right place for NCQA to lead. And I'm fired up to see what you and the team come up with. And I'm eager to be helpful if I can be.
We're at a very turbulent time in healthcare. So I'm going to ask you, what are you excited about and what are you worried about?
No one can say with a straight face that we're doing it all right. Obviously, there's lots of opportunity for us to get better. And I hope that as changes are implemented, that we do use this crisis as a way to get better rather than perpetuate other things that aren't working. This effort and focus on prevention and health, from just healthier behaviors, could be incredibly valuable for this country. I think we as a country not only are under-indexed on social services and over-indexed on medical services, we are decidedly under-indexed on efforts to keep people healthy in the first place. So there are opportunities for good things to happen. And I'm going to have everything crossed that as many of these pieces come together to improve the health of all Americans.
One of the things that this administration seems to be wanting to do is really push Medicare Advantage because it is an accountable structure. Leaving aside debates about how effectively that's been done, but 54% of Medicare beneficiaries are in a Medicare Advantage plan. I did another podcast with somebody who said these are really great for people because they save money, and people don't have a lot of money to spend on healthcare in their older years. But I just wondered, can Medicare Advantage be thought of as something that somebody that had other options would choose? Like somebody that has enough money that they could choose whatever they want in terms of a health plan. And what would that look like?
Seniors are choosing with their feet. More than half seniors have selected Medicare Advantage plans. Say what you will about the business tactics of these companies, they're delivering a more comprehensive set of benefits and a set of services that's more integrated than what patients get in the absence of Medicare Advantage. The traditional Medicare system is far from perfect. And in the spirit of systemness, I think there are more ways to capture and catch and support a patient in Medicare Advantage than there are in traditional Medicare. People are not just reacting to advertisements on TV. They're selecting these plans because they realize that there's value. Whether it's a broader set of benefits, we often see on TV, the vision, dental, there's a variety of different social needs that can be addressed through a Medicare Advantage plan that you don't get in a traditional Medicare plan. There is more of a fabric to surround and coordinate care for a patient. There are always going to be opportunities to drive more efficiency, and there's lots of questions about how coding impacts the total. But those are things that can be fixed. We can fix coding. We can fix STARS programs. But having some organization that's looking out for the population they serve, that's trying to be more proactive, that's trying to keep people healthy in the first place, that's trying to keep people out of the emergency room and out of the hospital, to me seems like a pretty good idea. Those that just sort of find fault with some of the financial behaviors and don't acknowledge the real benefits that come from Medicare Advantage plans are not seeing the whole story.
I agree with you. What else should I have asked you that I didn't ask you?
I think that was great. That was fun. Is there anything I should have said about you or anything I could ask back to you?
No. This is not about me. This is about,
No, you're the best, Peggy. You are the very, very, very best.
Make sure you don't cut that. It's been a privilege, I have to say. And I just wish we were further along, or at least felt like we were getting some traction on some of the things that, like your point about when you did the follow-up study on waste, the profile was looking pretty much the same, but the number was bigger, right? Yeah.
Well, you can never know what the counterfactual is. But I would imagine over the last X number of years, were there no Peggy and no NCQA, things would be a lot worse.
Thank you. I feel very honored to have you say that to me.
No, it's true. It's true. The NCQA has been a real source of good. I hope we just find more and more ways to celebrate Peggy O'Kane over the next year.
Well, thank you so much for joining us on Quality Talks.
Peggy, it is truly an honor to have a chance to talk to you. I'm your biggest fan, so it's awesome to have this conversation.
Several things stick with me from my conversation with Will Shrank. His description of wanting healthcare to function more like a true system is spot on. That's what NCQA has always been about. Systemness is a tough concept to convey, but it's essential if we want to see real improvement. Will is right that becoming a cohesive system means payers and providers need to collaborate and align incentives and get the way they operate not to rub against each other, but mesh in a way that feels seamless to the patient. His acknowledgement of NCQA's role in data integration and setting goals for providers is also encouraging. I agree with Will that quality measures can feel burdensome to providers and often don't capture the patient outcomes that we want. This highlights a critical need to both align measures across parts of the system and to work towards more meaningful and relevant metrics as long as they're fair to the person or the system we're evaluating. Another thing that resonates is Will's emphasis on the importance of keeping people healthy and preventing the progression of disease. His remarks remind us that prevention is central to quality and should be a core focus of our healthcare system. Finally, I appreciate Will's views on Medicare Advantage and value-based care. Both are promising, and Will emphasize that real change requires dedicated implementation and a focus on transforming care delivery. It was a pleasure to speak to Will. I hope you got as much out of the conversation as I did. Thank you for listening. Thank you for joining us this time on Quality Talks. If you enjoyed this podcast, please rate us 5 stars wherever you listen. We'll see you again next time.